have Dr. Prem Subramanian. I've already introduced you, doctor, and he's going to be talking to us on hereditary optic neuropathies. On to you.
Thank you. Okay, so I'm going to speak about hereditary optic neuropathies, and I will be focusing on two in particular, the two most common hereditary optic neuropathies, as there are many out there. Of relevance to this talk, I do have a financial interest in GenSight Biologics, which is the manufacturer of the gene therapy I will speak about. We'll start with one case, a 23-year-old man who had vision loss in the right eye 2 months ago. And this was painless. There was no accompanying trauma, no recent illness, and the vision didn't really recover. And as with many young men, he did not seek medical attention at that time, and rather did not come in until he now experienced vision loss in the fellow eye. And on examination, he has visual acuity of 660 in both eyes. He has poor color vision. There's no relative afferent pupillary defect, and he has brisk pupils bilaterally, and his anterior segment is normal. And I should also mention that he has no other relevant medical history. And on fundus exam, these were his optic nerves. And at first glance, they appear somewhat normal, although if we look at the left optic nerve, there is slight hyperemia and the characteristic pseudo-disc edema that is often seen in patients with this disorder. And so again, you know, this is a talk on hereditary optic neuropathies. You see a patient who has this pseudo-disc edema. He's a young man. He's had sequential painless vision loss, and his pupils are briskly reactive. All of these things are highly characteristic of Leber hereditary optic neuropathy. This is in fact the most common inherited optic neuropathy, although the precise incidence is not known. Studies have been done suggesting it may be, at least the carrier frequency may be as high as 15 in 100,000 in a UK population. What is interesting is that LHON is found throughout the world in different ethnic and racial populations. And so we still don't know if there is, like in sickle cell disease, a putative protective effect of being a carrier of this disease and not then getting the actual vision loss. That remains to be seen. But again, interestingly, the most common mutations, the 11778, the 14484, and the 3460 mutation are again found worldwide in ethnically and racially unrelated populations as far as we can tell. And there are numerous other less common mutations that have been identified now that we have easy access to mitochondrial sequencing for these patients in whom we suspect LHON. So when you suspect the disease, not only is it important to get testing for the three common mutations, but if possible, mitochondrial sequencing as well. We do know that there may be influence of nuclear genes. This disease, of course, has a male predilection, although females can be affected. Environmental factors also may figure into it: heavy smoking, heavy drinking, poor nutrition, as with other mitochondrial optic neuropathies you heard about, ethambutol and other toxic optic neuropathies, which are also mediated by mitochondrial dysfunction. And women, when they are affected, are typically affected later in life. Men usually in their early 20s or late teens, women in their 40s or 50s, perhaps related to a drop in estrogen as they approach the menopausal age. And the natural history of this disease, regardless of mutation, is that there is onset, progression usually over days, weeks, or months to a nadir, and then some degree of recovery, often 1 year or more out, with recovery spontaneously in the 14484 mutation to be most common, but there are other less commonly identified mutations also that may show spontaneous improvement. Now, there is no definitive treatment for this disease. Idebenone, which is a derivative of coenzyme Q10, ubiquinone, that gives it better permeability. Coenzyme Q10 has very poor permeability into the neuronal body, into the CNS. it's thought to be helpful in a few cases initially, and then has been studied more broadly because of its ability to potentially stabilize respiratory chain complexes. You may recall that LHON results from disruption of the oxidative phosphorylation pathways, just as another optic neuropathy that I will show you does. And so if we look at a clinical trial, RHODOS, that was performed to look at the efficacy of idebenone in patients with LHON, in 85 patients, 55 of whom were treated with idebenone, 900 milligrams divided TID, the outcome was a trend towards a better outcome in those patients who were treated, but it was not statistically significant. But looking at some of these charts, in particular, the right-hand graphs are in those patients who presented with discordant vision. One eye was worse than the other at presentation, maybe even not affected yet. There seemed to be in that population a more significant benefit from taking idebenone in terms of visual outcome than in those patients who had equally bad vision at the time of enrollment. Now, there are subsequent studies that have been done suggesting that idebenone use for 2, 3, even 5 years may be more beneficial than at 6 months, but it still remains unclear as to how much benefit patients get. Now, ultimately, this is a genetic disorder, a disorder of a mutation in the mitochondrial genes. Can we replace the defective gene? And gene therapy for LHON recently has been reported with an AAV2 delivery system replacing the ND4 gene to achieve high copy number gene expression. You can't delete the abnormal gene, but you can target a vector to the nucleus of the cell to produce a mitochondrially targeted good ND4 gene that then goes into the mitochondria and results in improved function. This has only been done for the 11778 mutation to date. It's been targeted by researchers because it is the most common mutation. At least 2/3 of patients with LHON potentially could benefit from this therapy. These were the baseline characteristics of patients who were enrolled in a phase 3 clinical trial of unilateral or bilateral gene therapy. So you can see typical of most patients with LHON, where most patients had 60 or worse vision at enrollment. And you can see that there is, not surprisingly, a linear correlation between the degree of vision loss and contrast sensitivity. Contrast sensitivity is something that seems to be preferentially affected in hereditary optic neuropathies. So a cohort of 98 patients was enrolled, and they were treated either with bilateral gene therapy or with gene therapy in their first affected eye and a placebo injection into their second affected eye, and they're being followed out to 5 years. Now, the primary endpoint was at 18 months, and those results have been reported. And at 18 months, you can see now this, to orient you to these graphs, red is the patients who got bilateral gene therapy injection. The green is the fellow eye, the second affected eye with bilateral injection. The orange is the patients who got injection in their affected eye, and placebo in the other eye, and the light green is the placebo injected eye itself. And what we can see is that giving bilateral injection, the first affected eye improved more than the second affected eye, not surprisingly, but even a placebo injected second eye had some degree of improvement. And this was seen in earlier studies where only a unilateral injection was given. I don't have time to discuss that. Primate studies showed that the vector is actually transported via the optic chiasm from one eye to the other, a fascinating outcome. But promising results for treating our patients who have LHON, something better than idebenone. The other most common optic neuropathy is typically discovered. This patient, 46 years old, failed her driver license exam, which she had always passed before. And she had been prescribed glasses in childhood. She was always seated at the front of the class, never good at ball sports. Her visual acuity is mildly reduced, 618 and 615. She has poor color vision bilaterally, no RAPD. And here you see on fundus exam, there is subtle but definite temporal pallor bilaterally, a symmetric appearance, but no acute pathology. This is, of course, how patients with autosomal dominant optic atrophy present. Now, this is a highly heterogeneous disorder, unlike the mitochondrial mutations of LHON, and in fact arises from a somatic gene mutation on chromosome 3. The OPA1 gene was a very large gene, but again, it encodes a mitochondrial gene that is important for oxidative phosphorylation, and when it is not functioning properly, reactive oxygen species develop, leading to retinal ganglion cell damage and atrophy. As I suggested, this is a very large gene, 31 exons, including a mitochondrial targeting sequence and domains as shown here, and it forms a dimer as demonstrated here in figure B that is then on the surface of the mitochondria and is involved again in oxidative phosphorylation. Dysfunction of this gene, unlike in LHON, again, doesn't cause sudden vision loss, but results in a gradual dysfunction. But what's more important is that at least a third of patients with autosomal dominant optic atrophy may have ADOA plus, where they can have cardiac or skeletal muscle or other problems. And it is interesting that the mutation that causes classic ADOA is a deletion rather than missense mutations with ADOA plus, indicating something to us about how the dysfunction affects different parts of the body. And mutations in certain regions of the gene are more likely to cause multiple systemic manifestations of disease. And it is more likely in patients where they inherit it from the maternal side that they are going to have these systemic manifestations. So it is critical that we look for things like pigmentary retinopathy, cardiac conduction defects, because cardiac conduction defects can kill our patients. Decreased vision, of course, is a hindrance, but we want to recognize these other life-threatening disorders as well in these patients. So in conclusion, inherited optic neuropathies may present or be discovered. Toxic and nutritional optic neuropathies also result from mitochondrial dysfunction, and we can learn a lot about hereditary optic neuropathies from those diseases as well. The spectrum of mitochondrial disease continues to grow, and treatment strategies are evolving. Thank you for your attention.
Thank you very much. That was a brilliant talk, Dr. Prem Subramanian. Would you consider an autosomal dominant optic atrophy in normal parents?
Yes, because many patients can be asymptomatic. At least a quarter of patients don't have symptomatic vision loss. So if you examine the parents, you may see that they have some temporal pallor. It may be subtle, but absolutely it can be manifest in a child who has relatively asymptomatic parents.
Murli, any question to other expert panel?
Yeah, I have a question, Dr. Prem. In Leber's hereditary optic neuropathy, is it always a sequential vision loss? I mean, sometimes we find that both eyes are already into optic atrophy, and when we test, we get the LHON mutation positive. So is it always a sequential vision loss, or could it be something atypical like a simultaneous or
Absolutely
gradual?
can be simultaneous. At least 20% of patients may present simultaneously.